Good evening. I am Elitar Palma Jr. and I will be reporting neurosurgery. What is neurosurgery? Neurosurgery is a surgical specialization that treats disorder of the brain, spinal cord, spinal column, and peripheral nerves with all parts of the body and other neurological dysfunction. Back pain is one of the indicators of neurological dysfunction. It produces neurological symptoms such as numbness, muscle weakness, loss of bowel, and bladder control. Neurosurgical care includes both adult and pediatric patients, and neurosurgeon may provide surgical and non-surgical care. History of neurosurgery. Harvey Cushing is the father of neurosurgery. He performed the first operation for brain tumor, and Walter Dandy, who performed the first aneurysm clipping in 1937. The history of neurosurgery is filled with courageous individuals who work against great odds in attempt to improve the lives of their patients. For centuries, the realm of neurosurgery was considered an arena mostly of observation and primum non nocere, as surgical outcomes were often worse than disease progression. The Hippocratic school was the first to codify treatment for head injury in Lecaptis vulneribus, with skull fractures being classified by the type and the severity of injury, determining the need for trepanation. The worse the injury, the less the need for trepanation. Furthermore, this work did not provide any clues that the neurological condition of the patient made any difference in the surgical decision-making process. Types of surgery. Neurosurgery. Anterior cervical discectomy, craniotomy, and chiari decompression. Epilepsy. Anterior cervical discectomy. Anterior cervical discectomy is a procedure in which a disc is removed from the front of the word discectomy refers to the removal of a disc. When a herniated disc causes extreme neck pain that is unmanageable despite alternative therapies including physiotherapy, surgery is preferred, in which the troubled disc is removed, providing a permanent remedy. Patients who have chronic pain in their neck and back as a result of disc issue are candidates for this surgery. It removes the degenerative disc from the neck and then fuses bone together. On the day of surgery, patients are permitted to go home. Sa anterior cervical discectomy and fusion, inaalis lang yung herniated disc, then after niyang maalis, i-fuses yung bone para mag-function siya ulit. Preoperative nursing management. Attend any schedule appointment for blood test, X-ray, or electrocardiogram para malaman kung normal yung result ng ECG mo. Then, through test, nalalaman yung result ng laboratory mo if ever qualified kang i-undergo yung procedure. Sign a consent form and share your medical history with your doctors. Lagi nating tatandaan na before the procedure, kailangan nating makuha ang consent ng ating patient and then i-inform natin sila about sa gagawing procedure, then inform the family as well para alam nila kung anong klaseng procedure yung gagawin sa'yo para maiwasan yung mga hindi inaasang pangyayari. Tell your doctor about any medication or dietary supplements, herbal or otherwise, that you are currently taking. Then, if ever the patient has supplements
Dietary supplements or medication intakes, kailangan mo na yung i-stop before the surgery. Don't smoke before the procedure. If possible, try to quit 6 months before the surgery, as smoking can slow down the healing process. This includes cigars, chewing tobacco, and electronic vapor, cigarettes, or vape. Don't drink any alcohol about a week before the procedure. Don't take any non-steroidal and anti-inflammatory drugs such as ibuprofen, Advil, or blood thinners such as warfarin or Coumadin about a week before the procedure kasi it can cause bleeding sa patient. Get a few days off to work para ma-prepare ka din sa surgery, para maging stable ka. Then, after surgery, kailangan pa rin magpahinga for the fast recovery. Post-operative nursing management. Activity limitation. You may feel weak and tired for a couple of weeks after surgery. We encourage you to try to get back to your work, regular, daily activities as soon as you can tolerate them. You can slowly do this that allows to rest periods throughout the day. Activity, especially walking around your home, is encouraged. Try to do so at least 4 times daily. Slowly increase the amount of your walk and use arm every day. Do not stay in one position. Dun sa patient na nag-undergo ng surgery, may strict to ang activities. May mga activities silang hindi pwedeng gawin kasi hindi pa nila kaya at makakasagabal yun sa kanilang recovery. Then, ambulatory activities lang like walking, then lifting light materials, yun lang ang pwede nilang gawin. Diet. After anterior cervical spine surgery, it is very common to have a temporary sore throat or temporary difficulty swallowing. This occurs your trachea and esophagus lie in front of the spine and must gently be held aside during surgery. The symptoms gradually subside over a few weeks. Sometimes, the trouble with swallowing may persist for a lot longer after surgery, especially when eating dry foods or large pieces of meat and have not been thoroughly chewed. You can gradually resume your regular diet as you can tolerate. Sa diet naman, after the surgery, ini-encourage yung mga patient na soft diet lang yung kainin nila kasi yung throat nila is inflamed pa dahil dun sa surgery. Incision care. The bandage should be taken off your neck before you go home at least once. We typically reapply a new bandage before the patient is discharged home. Usually, the incision should no longer needed to be recovered after 2 to 3 days. Do not apply anything to incision unless instructed. Unless you were told otherwise prior to discharge, you may take the dressing off in 2 to 3 days and shower with mild soap. Small dot of dry bloods or reddish-brown discharge is not uncommon after removing the dressing. You should avoid touching or rubbing the incision and do not soak in the bath for 2 weeks after surgery. You should dry your incision carefully after shower. You will need to purchase a staple remover when leaving the hospital. Incision care. Pwedeng i-wash yung incision site using mild soap, then warm water. Then, huwag din nating ilalab yung incision site or Huwag tayong maglagay ng like ointment kasi pwede siyang mag-cause ng infection sa sugat. Medication. When you return home, you may continue to take your own medication unless your doctor tells you otherwise. You will likely have some pain, discomfort at the site of the operation, and mild swelling and redness around incision for at least 1 to 2 weeks. After all surgeries, inflammation is all natural process of healing. We cannot and do not want to block this process. Please know that medication can take the edge of your pain, but we may not be able to stop all your pain. With each day that passes, you should stronger and oftentimes must simply be patient as the healing process begins. Feel encouraged by the good days as the bad days get farther apart. Follow-up appointment. Unless otherwise indicated, at the time of discharge, your first operative appointment will be approximately 6 to 8 weeks following your surgery. Return to work. This may be different depending on many factors including degree of symptoms, prior to surgery, patient body response to surgery, and type of work. Generally speaking, most patients can return to work about 6 weeks after surgery. This occurs in graded fashion and with gradually increasing R as per the patient tolerance. Craniotomy. Craniotomy is a surgical procedure that involves the removal of the skull. A portion of the skull bone is removed in the surgical procedure to allow direct access to the brain underneath. This surgery can effectively treat a variety of neurosurgical disorders. After the surgery is performed successfully, the bone slab, the dissected part of the skull, is replaced, leaving no sign of the disruption. Preoperative nursing management. Inform consent from your physician para alam nung patient at nung relatives yung procedure na gagawin sa patient. Alam nila yung support na kailangan nilang ibigay sa patient. Preoperative teaching printed material is useful. In planned surgeries, routine tests are completed as outpatient. Sa mga outpatient na mag-undergo ng procedure, kailangan nilang ikumpleto yung test para malaman kung fit silang mag-undergo ng procedure at walang magiging problema pag nag-undergo siya ng procedure. Patient is kept NPO after midnight. As possible, every patient na mag-undergo ng surgery is nagpa-fasting para maiwasan yung obstruction in the day of surgery. Patients are asked to wash hair and skin with pre-op skin prep detergent evening before the morning of OR. Long hair is braided. Anti-embolic shocking are worn. Neurosurgical assessment and vital signs are recorded. Post-operative nursing management. Post-anesthesia care unit or straight ICU. Transfer should include overview of surgery, reason, anatomical approach, length. History of pre-existing neurological deficits, pre-existing medical problems. Review post-operative order. Information to family. Chiari decompression. This procedure entails the removal of bone from the back of the skull and spine in order to widen the foramen magnum, which leads to the brain. The surgical procedure stops the symptoms from getting worse and restores the normal flow of the cerebrospinal fluid. Sa chiari decompression, inaalis yung portion ng bone sa likod para maka-flow ng maayos yung cerebrospinal fluid. Then, ang mga preoperative nursing management under charity decompression are preparation for surgery for charity decompression is the same as for any elective surgery and depth on the patient's general health. The author routinely obtains CBC, basal metabolic panel, PT, EPTT, chest radiograph, and ECG. Blood is typed and screened. The patient is restricted to nothing by mouth or in PO after midnight and admitted to the morning of surgery para maiwasan yung obstruction. Tie-high and anti-embolic stocking and sequential compression devices are applied. Antibiotic prophylaxis with cefazolin or vancomycin is given within 1 hour of making the incision. Post-operative nursing care. The patient is carefully observed during the first 24 hours after surgery for any signs of brainstem dysfunction, particularly apnea, which is rare but serious complication of CRE surgery. CRE decompression, after niyang i-undergo yung procedure, kailangan muna niyang i-monitor ng doctor or ng nurse para malaman if may brainstem dysfunction. Then, para na rin malaman kung may apnea yung patient. In author's practice, all CRE patients for the first preoperative night in the ICU. Yung mga patient nag-undergo ng ganitong procedure, dinadala nila ito agad sa ICU para ma-monitor. The patients are then rapidly mobilized and usually discharged home by the end of post-operative day 2, as long as they are neurological intact, ambulatory, and able to eat without vomiting. After 2 days of monitoring sa ICU, pag okay ng patient, pag hindi na siya nasusuka, pag kaya na niya ang sarili niya and nakaka-recover na siya, pwede na siyang umuwi. Incisional pain and muscle spasm are common and are controlled with opiate analgesic and muscle relaxant. Some patients obtain partial pain relief by use of soft cervical collar. Nausea and vomiting are also common and may prolong the hospitalization. Pag yung patient nag-undergo ng procedure na to is sumusuka pa or nasusuka, di pa siya pwedeng i-discharge. Kailangan pa siyang i-monitor, then kailangan pa niya nang magstay sa hospital hanggang sa maging okay yung kanyang health status. Epilepsy surgery. When seizure originated in a specific region of your brain, the surgery removes or modifies that area to restore normal brain function. It is most successful when seizure occur in only one part of the brain. Doctor prescribed epilepsy surgery if anti-seizure treatment fails to function. Types of epilepsy surgery. Sa 2 types, meron siyang 2 types, curative procedure and palliative. Sa palliative procedure, yung nasa specific area ng brain, yung seizure. Then sa palliative, walang exact location, yung di pa natutukoy yung exact location kung saan nagmula yung seizure. Curative procedure are performed when the surgery test consists point the specific area of the brain where the seizure begins. Temporal lobectomy, common type of surgery. For people with temporal lobe epilepsy, it removes part of the anterior temporal lobe along with the amygdala and hippocampus. A temporal lobectomy leads to significant reduction or complete seizure control about 70% to 80% of the time. However, memory and language can be affected and this process is performed on the dominant hemisphere. Cortical excision. Second most type of epilepsy surgery. It removes the outer layer cortex of the brain at the seizure focus area. About 40 to 50% of the patients have better seizure control. Hemispherectomy involves the removal of the brain outer layer cortex and anterior temporal lobe on half of the brain. It usually performed on children who suffer intractable seizure, have damaged hemisphere, and experience weakness on the side of the body. Surgery may control seizure for nearly 80% of the patient. Patients often improve in cognitive functioning, attention span, and behavior. Second type of epilepsy surgery is the palliative procedure. Palliative procedures are performed when the seizure focus cannot be determined or it overlaps brain areas critical for movement, speech, or vision. Under palliative procedure is corpus callosotomy, prevent the spread of generalized seizure from one side of the brain to the other by disconnecting the nerve fibers across the corpus callosum. During surgery, the anterior two-thirds of the corpus callosum is sectioned. On occasion, a surgery is performed because the posterior one-third of the patient does not improve. The surgery is not curative, rather it prevents this and reduce the seizure severity. Some patients experience disconnection syndromes after a complete callosotomy. They may have right-left confusion with motor problems, apathy, or mutism. Multiple subtial transection create a small incision in the brain to interfere with the spread of seizure impulses. This technique is used when the seizure focus is located in a vital area that cannot be removed. It may be used alone or in combination with a lobectomy. Vagus nerve stimulation or VNS involves implant of the device that produces electrical signal to prevent seizure. VNS is similar to heart pacemaker. A wire is wrapped around the vagus nerve in the neck. The wire is connected to the generator battery implanted under the skin near the collar bone. The generator is programmed to produce intermittent electrical signal that travels along the vagus nerve to the brain. This procedure is reserved for those who are not candidates for potentially curative brain surgery. Ang pagkakaiba ng curative sa palliative, sa curative, inaalis nila yung damage dun sa brain kung saan nagmula yung pinagmumula ng seizure or epilepsy, samantalang sa palliative procedure is binablock lang nila yung pagdami or paglala ng seizure. Preoperative nursing management. Continuous video EEG monitoring requires hospital stay in an epilepsy monitoring unit for the EEG. An electrician glues electrodes on your scalp to record the electrical activity of the brain. Magnetic resonance imaging or MRI helps identify structural brain abnormalities and that can cause epilepsy. This includes hippocampal atrophy, cavernous adenomas, cortical dysplasia, and tumors. Position emission tomography allows the doctors to study brain function by observing how glucose is metabolized in the brain. Single photon emission topography or SPECT provide information about blood flow to brain tissues. Neuropsychological testing evaluates your current brain functioning including memory and language. WADA test or intracarotid amyloid test is determine which side of your brain is dominant for your memory and language function. Functional MRI used to determine brain abnormalities in relation to areas of the brain responsible for speech, memory, and movement. Electrical brain mapping or electrocorticography. Diagnostic tests that may be necessary if the seizure focus is it believed lie close to important function areas or if the exact location of the seizure focus remain unclear despite of standard EEG and other tests. Under electrical brain mapping is subdural electrodes aligned on plastic grid placed directly on brain surface. It allows wide area of EEG recording as well as cortical mapping functional areas. Then second is intracerebral depth electrodes look like bandage stick. These are placed stereotactically deep into the brain tissue, usually the amygdala and hippocampus of the temporal lobe. Depth electrodes are indicated for patients with bitemporal, prefrontal, or frontal temporal seizure. Continue to take your regular seizure medication as prescribed. Eat a healthy diet and stay well hydrated. Practice good sleep habits. Stay active in the best shape possible. This will help as you recover from surgery. Follow all pre-surgery instructions. You may be asked to stop medication that may increase your risk for bleeding. Complete any lab test for other tests ordered by your epilepsy team or the pre-surgical evaluation team, such as internist and anesthesiologist. Meet with your internist or other specialists if needed, such as cardiologist, pulmonologist, or psychiatrist, and review your plans for surgery and any concerns you may have. Discuss your upcoming epilepsy surgery with your primary care doctor. He or she will be an important part of your support team before and after epilepsy surgery. When you are ready, notify the people closest to you about your plans for surgery and how they can best support your decision and be there for you as you recover. Post-operative nursing management is restriction. Do not lift anything tight bound to strenuous activity, including yard work, housework, and sex. Don't drink alcohol and don't mix alcohol with pain medication. Don't smoke or use nicotine products. Don't drive return to work. Incision care. You may shower the day after surgery and wash your hair with mild baby shampoo. Gently wash your incision area with soap and water every day. Don't scrub or let the water beat hard your incision. Pat dry. If there are bad skin glue over your incision, don't rub or pick at the glue. Don't color your hair for 6 weeks. Don't submerge the incision in the bath. You may hear strange noise like popping, cracking, and ringing inside your head. It is normal as the fluid and air reabsorb. Medication. Headaches are common after surgery. You may take acetaminophen or Tylenol. Take pain medication as directed by the surgeon. Reduce the amount and frequency of subsides. If you don't need pain medication, don't take it. Kung kaya mo namang Kung kaya mo naman yung sakit na nararamdaman mo after the surgery, pwede naman na wag mo nang i-take yung pain medication. Choice ng patient if mag-take siya ng pain medication or hindi na. Narcotics can cause constipation. Drink a lot of water, eat high fiber, laxative helps move the bowel. Colace, Senocort, Dulcolax, and Miralax are over-the-counter drugs options. Anti-seizure medication may be prescribed. Some patients develop side effects such as drowsiness, balance problem, or rashes. Don't take anti-inflammatory pain relievers such as Advil or Aleve, blood thinner, or supplements without surgeon approval kasi pwede siyang magdagdag sa bleeding. Activity. Get up and walk 5 to 10 minutes every 3 to 4 hours. Swelling and bruising of the eyes may occur. Sleep with your head elevated and apply ice 3 to 4 times per day for 15 to 20 minutes to help reduce pain and swelling. Thank you.